Thank you so much, Jenna, and Maya as well. Okay, so now we have Monica Hahn and Guy Vandenberg. Welcome. Thanks so much, everybody, for being here. It's really an honor. So we're here to talk about a provider update of HIV and Safer Conception, and particularly we're going to go through clinical updates about PrEP, TasP, and assisted reproductive technologies. So this is the outline of what we're going to go through. So first, just starting with framing an overview of preconception health for different couples. We're gonna basically walk through the different tools that we have for safer conception by going through case examples. It's always more fun than just blah, blah, blahing about each of the techniques. And then talk about some resources and Q&A and discussion at the end. Hopefully we'll have some time for that. So we wanted to start with just a poll. These may seem like very simple questions that maybe all of you already know the answer to. But it's questions that come up for our patients all the time. And often when these questions come up for them, they've often been told by providers and by other people that they've met totally the wrong answer. So we wanted to start by asking this of the room. So first, true or false? If you are living with HIV and are pregnant, your baby will always be born with HIV unless your viral load is undetectable. Can we get a show of hands? How many people think that's true? Okay, sure. And how many people think that's false? Sure. And it's okay because a lot of people didn't raise their hand because it's not always very, very obvious. And so the correct answer is false. So if you are living with HIV and are pregnant, your baby will not always be born with HIV, even if your viral load is not undetectable. And we'll be going through more of this through this presentation. So let's go to the next question. Yeah, do you want to ask it, or do you?
Okay. So what if you're not living with HIV and you're pregnant? Your baby can be born with HIV if your partner is or sperm donor is living with HIV. Is that true or false?
How many people think that's true? Okay, sure. And how many people think that's false? Great. So yeah, so more people think it's false. And the correct answer is?
It's also false. So it's also false.
Right. So yeah, it's hard. It's hard. So yeah, so if you are not, to be very clear, if you're not living with HIV and you are pregnant, there's basically no way your baby can be born with HIV. As long as the pregnant parent is HIV negative, baby will be negative. So yeah, thanks. So we'll go to the next poll question, piggybacking off of that. So without, this is multiple choice, without ART or PrEP, what percentage of babies born to a person living with HIV would acquire HIV? So in essence, this is asking what is the rate of perinatal or vertical transmission in the absence of any ART? So how many people think it's 100%? A. How many people think it's 65 to 99%? Sure, okay, couple votes. How many people think 45 to 65%? A couple. And 15 to 45%? A lot of hands. And how about less than 10%? Couple. Great. So yeah, so we're all over the board. And the answer is?
The answer is D. So remember, this is about without ART or PrEP. So right. Vertical transmission without ART or PrEP, the transmission is 15 to 5%.
Right. These are according to the WHO numbers, and it's quite a range. Oh, thank you. So thank you for participating in that. I think it's helpful to go through. And this is just a pictorial of the different phases during periconception, pregnancy, and postpartum when perinatal transmission can occur. So I like to start off really any presentation regarding reproductive health with a framing in terms of reproductive justice and sex positivity. And Jenna already did a really awesome job starting us off with talking about reproductive justice. So I'll just quickly review. I like Sister Song's reproductive justice definition, which is the human right to maintain bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. And I really appreciate this reproductive justice framework that it addresses and focuses on intersectionality and the structural inequities that affect our reproductive health. And it's especially relevant to our patients living with HIV who often are from communities that experience disproportionate structural inequities, and also so relevant to our LGBTQ patients whose reproductive desires are just all too often completely neglected in our healthcare system. And I also want to quickly review sex positivity. Basically, it's simply the idea that all sex, as long as it's healthy and explicitly consensual, is a positive thing. And all too often what we experience, again, in the clinical setting is that it can be quite fear-based and sex negative, especially when we're talking about STIs, and that's including HIV. And so, we believe that everyone should have the sex lives and families that they deserve and want without judgment, discrimination, or stigma. So when we're talking about the goals of HIV-centered preconception care, this is actually not too different when we're talking about all regular primary care health, your overall general health. So this includes optimizing overall health for everyone. So this is healthy diet, exercise, vaccines, avoiding tobacco, screening for, reducing the risk for, and treating STIs, reducing exposure to potentially harmful medications and substances. Some of my favorite resources for this are Reprotox and LactMed. Remember to really do a comprehensive medication review, including over-the-counter medicines and alternative medicines. Most of the routinely used antiretrovirals that we use these days are safe in pregnancy, but some really common, like hypertensive meds, for instance, are not, and some over-the-counters are not. So it's very important to ask about those. And we counsel patients to take a prenatal vitamin with folic acid as well. This is preferably, we would ask people to try to start this before they attempt to get pregnant, because the folic acid is very needed for neural tube development very early in pregnancy, even before people may realize that they're pregnant. And of course, all of the things that I just mentioned apply to everybody, regardless of HIV status. But for our serodifferent couples, preventing HIV transmission to negative partners and to the infant is also our goal. And so our vision is a world where HIV is not a barrier to sexual wellness and family building. And I know I'm particularly biased because I'm a family doctor, but I really believe that this will be best achieved by integrating all of these concepts into HIV-centered sexual and reproductive health primary care. And what would successful integration look like? In an ideal world, all patients, including men and our LGBTQ patients, would be asked about reproductive desires and sexual health in a sex-positive way in our regular health visits. All patients would be, and this would be with the goal to help our patients have pregnancies that are planned and well-timed. And all patients would be asked about sexual health in a sex-positive way without judgment or shaming. People living with HIV would be given support for disclosure to loved ones. So many of our patients face a really heavy burden of secrecy when it comes to their diagnosis, and just so much stigma around that diagnosis as well. And just a big part of HIV justice is to break down the walls of HIV stigma. And one of the more powerful things we can do as frontline staff and providers is to support our patients in their efforts to disclose. And ideally, partners living with HIV would be linked to care as well, and counseled about the tools to reduce the risk for HIV, and also engaged in a shared decision-making discussion about their health as well as the rest of their family's health. At Hive Clinic and at Family Health Center HIV Clinic where I work, basically when one person becomes our patient, their entire family becomes our patients. And they just become a part of our family as well. And a big goal, of course, is zero HIV transmissions to infants or negative partners. And in San Francisco, we have had 0 babies born with HIV since 2005. And that's, we're working really hard to keep it that way, and with all of you in the room here as a partner in this. Yeah, it's amazing. And finally, we really believe that strong support should continue before, during, and after pregnancy. We're finding more and more with our experience that actually the postpartum period is a really vulnerable and challenging time for a lot of our patients, and they really need our support during that time. So starting with a case, Julia and Fernando. And by the way, all of these cases are informed and modeled after real patients of ours that we've learned so much about, or we've learned so much from throughout the years, but all these names are made up. So Julia is a 34-year-old woman living with HIV, diagnosed in El Salvador many years ago. She has a high CD4 count of 790, undetectable viral load for over 7 years, basically since she immigrated to the US and started ARVs, has had 100% adherence. And she has really desired starting a family with her fiance, Fernando, who's not living with HIV. And neither of them have any known fertility issues. But something really disturbing she tells you is that she has been told by doctors in the past, in her country as well as here, that basically it would be impossible for her to have children because it would not be safe due to her HIV status. And this has been really devastating to her self-esteem and her identity, and has strained her relationship at times. So what would the options be for this couple? This is another poll. So A, sperm washing with in-clinic insemination is the first-line risk reduction technique for a series of different couples. Home insemination using Fernando's sperm or sperm from the donor. He could take daily PrEP to lower his risk. He can take postcoital PEP to lower his risk. A plain old-fashioned condom sex is perfectly safe. Surrogacy or adoption. I won't go through each one and have people, but just think about what you might offer this couple. And basically, there's no one right answer. You know, the only one that's truly incorrect is A. It may have been true as a first-line tool several years ago, but luckily not anymore in the absence of a fertility issue. And so, you know, all the other ones are reasonable. C and E would be the first ones that we would initially focus on for this couple. So we'll talk a little more about them. So in different couples or mixed status couples where one partner is living with HIV and the other is not, basically the goal is to prevent HIV transmission to the negative partner and prevent perinatal transmission to the infant. And there are several tools in our toolbox, basically, in order to achieve this. And we would have a shared decision-making discussion with a couple to talk about what would work best for them and what would be the best options for their specific unique situations, since every couple is unique. And so we recommend checking an HIV viral load monthly during pregnancy in this case, and we recommend STI screening for all as well. And just to talk a little bit about what would we do to reduce Fernando's risk of acquiring HIV, so remembering that he has a partner living with HIV and he is not. And so, you know, we can talk about all these very fancy, expensive reproductive technologies, and we will in a little bit. Guys, got to go over all that. But one thing that we really talk about for everybody, and what is the most effective tool that we emphasize for everyone, and it's basically free, and it's TasP, treatment is prevention. And it means what it sounds like. I know Jenna went over some of this already, but really to break it down, when people living with HIV are taking their ARVs and they are suppressing their viral loads to an undetectable level, basically they're essentially making themselves unable to transmit HIV to others. And it turns out this has really huge, not just personal, but also public health implications. And you know, this was best demonstrated by early on by the HPTN 052 trial. This was a trial that was done with 0 different couples, where basically one arm of the study was an early therapy study where ARVs were started regardless of CD4 count in the partners living with HIV. And then the other arm it was compared to was a delayed therapy arm, where the partners living with HIV didn't start ART until their CD4 count dropped to less than 350. And so this basically showed that of all the transmissions that happened during the study, there were 46 of them. Almost all of them happened in the delayed ART therapy arm. And so basically it showed that there was a 93 to 96% reduction in HIV transmissions to negative partners if the partner living with HIV was on ART early. And really when they analyzed this further in 2015, they showed that there were 0 linked transmissions when the partner living with HIV was on ART for 3 months and was undetectable. And so again, huge personal and public health benefits from ART use. And then further, the partner study in 2016 and then opposite attract study more recently in 2017 found the same thing. Basically, 0 different couples with undetectable partners living with HIV basically did not transmit HIV to their negative partners. And these last 2 studies involved a lot more MSM, which the prior studies did not. And so really, this is TasP. The science behind it is very, very robust. And so this brings us to U=U that Jenna also mentioned. So how many people here have seen like an ad on a bus stop or like a bus recently? So yeah, a few people. They've been having some in San Francisco recently. And so basically what U=U means is undetectable equals untransmittable. And according to the CDC in 2017, people who take ART daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. And this is really huge. In 2008, the Swiss were, saying this, they've been saying this the longest. They won the prize for being the boldest and the bravest. And, they said this way before we could get any mainstream bodies like the CDC, IAS, UNAIDS to get on board with this science and clearly state that it's very robust. And so to get to the point where you could see U=U at a bus stop took an amazing amount of advocacy by the community activists and researchers. And this is one of my favorite quotes from Bruce Richmond from the Prevention Access Campaign that I love, that really sums up why U=U is so groundbreaking in dismantling stigma and promoting HIV justice. He says, HIV stigma is a public health crisis, and yet many people in positions of power are still sitting on their hands, overstating risk and not sharing this life-changing information. We need people to move away from controlling people with HIV and towards trusting people with HIV. And so getting back to Julia's case, as far as HIV and pregnancy, where she's living with HIV and she wants to get pregnant, what is the risk of perinatal transmission to her infant? We talked before about how in the absence of ART, that risk can range between 15 and 45%. And we won't be discussing HIV and pregnancy in detail today. That could be a whole other training, of course. But basically, I'll say what we tell our patients is something like this. We say, we know that taking ART, maintaining an undetectable viral load before conception and throughout pregnancy, avoiding breastfeeding or chest feeding, and giving the infant medicine as prescribed virtually eliminates the risk of HIV transmission. And I'll say something like, Julia, if you can do all of these things with us supporting you 100%, you will not pass HIV to your baby. And for somebody like Julia who has never been told something like this in a positive light ever in her life, it can be really life-changing. So we'll go to the next case of Janet and James. So Janet is a 23-year-old female with no significant past medical history, no primary care home, hoping to find a primary care doctor and to start a family with her partner James, who is a male partner who is living with HIV. And James has a PCP at a different clinic. He's been taking ARVs for the last year or so. He's been able to achieve an undetectable viral load. But admittedly has had some past difficulty with adherence in the setting of alcohol and substance use disorder. And now he's in recovery and doing great. They're both students, they're both very, very busy. And Janet found your clinic and she wants to establish primary care after she's been told by other providers that basically she would be completely irresponsible to consider having a child with a partner like James due to HIV risk to herself and the risk of her child. And so this has resulted in great mistrust in the medical system, and she's coming to you for this reason. So what do you recommend for this couple? So similar answers. So sperm washing with in-clinic insemination, just have plain old-fashioned condomless sex, no need for anything else. She should always use condoms and use PrEP if the condom breaks. And she can add taking PrEP to lower her risk. Or I'm not sure, I need more information. And I won't have people vote, but I just think in your mind what you would say. And again, there's really no right answer. You know, several of these options would work for this couple, with B and D being the likely best initial ones that we would go for. But they were this couple was particularly interested in learning more about PrEP. Oh, and I will say before I change the slide too, that Janet in particular had told us that all the providers she had seen in the past had told her, you can never have sex without a condom. So what is PrEP exactly? Oh, and also Janet has told you that basically you are the very first provider that has ever talked to her about PrEP. Why had nobody ever told her about PrEP before? She thinks maybe she saw an ad at a bus stop one time, but she didn't pay any attention because she thought it was only for men. So she asked you, what is PrEP exactly? So you tell her PrEP is a medication that works to prevent the HIV virus from taking hold and replicating in the body. And is over 90% effective at preventing sexual HIV transmission to an HIV negative person, if taken as prescribed. And it's taken orally once a day. And basically something really important is that the efficacy unfortunately decreases with less frequent dosing. And so, you know, this was very evident in a lot of the large trials, including IPREX, which showed that basically the higher the adherence to PrEP, the higher the effectiveness. And so how long do you need to be on PrEP before it's effective? Luckily, with rectal tissue, it takes about 7 days to really concentrate there pretty quickly and be effective. Unfortunately, for cervical vaginal exposure and for blood exposure, it takes a bit longer. We tend to counsel people to wait about a month, so at least 20 days, we think. And then side effects wise, mostly they're GI side effects. About 10 to 20% of people experience an initial startup syndrome, which includes abdominal pain, nausea, diarrhea, and weight loss, sometimes headache. It usually resolves spontaneously. And as far as what do we know about the safety of PrEP in the preconception period? Sometimes we call this PrEPception. We won't review all these studies in detail. There's a lot of them, but you can see references and we can talk more about it as well. But generally, we think that PrEP is safe during pregnancy, during preconception, pregnancy, and during breast or chest feeding. And a small amount of the drug does get into the breast milk compartments, but it's not thought to harm the infant at all. The antiretroviral pregnancy registry shows no evidence of adverse effects to fetuses exposed to PrEP. And these medications have actually been studied before during pregnancy in the setting of hepatitis B treatment during pregnancy. So it's not like it's a new drug. And very few small studies done with women who took PrEP around the preconception period showed no adverse events and no HIV transmissions to negative partners. These are just another shout out to our patient education materials that we love going over. They're all on the Hive website. But they really help us counsel our patients like Janet and James. So getting back to them, again, we had all these different options that we review with them. We of course review U equals U with everybody, and basically counsel that if James maintains an undetectable viral load, this will ensure that HIV is not transmitted to Janet. And then if that's avoided, then that eliminates the risk of perinatal HIV transmission to the infant as well. Remember that the infant doesn't even need to be tested for HIV. As long as Janet is negative, that's the end of the story. But we basically also discuss that if there were to be an acute HIV transmission during pregnancy or during chest feeding, basically the risk of HIV transmission to the infant would rise. And that's because in the setting of acute transmission, if Janet were to become HIV positive in this time period, your viral load shoots up really high initially when the virus is replicating. And so that would put her at risk for transmitting to the infant during that time. And so for that reason, we do recommend that the partner living with HIV, their viral load be checked monthly during pregnancy and during breastfeeding or chest feeding. And so James was really great and agreed to sign a release of information for his PCP so that we could communicate with them and get a viral load results for him basically reported to us. And we recommended that Janet be screened for HIV as well, at least once per trimester and more often if appropriate. And we would consider giving PEP if she were ever to have a known viremic exposure as well. And then this is the question that comes up often in couples like this is there really any added benefit to PrEP if you're already using TasP? Because we just talked about how U equals U, right? And basically, yes, what we feel is that PrEP provides really little added benefit, if anything, when the partner living with HIV is on ART and consistently undetectable, and if there are no other outside partners contributing risk to HIV. And so these are two really big, important things to remember. You know, it's not super easy for anybody who's living with HIV to take medicines every day. This is regardless of condition, right? I had trouble remembering to take my prenatal vitamin every day, and that was only for 9 months that I was supposed to do that. It's basically staying consistently undetectable is not something that's super easy for every single person. And then the other point about no other outside partners contributing risk for HIV, in all the studies that we talked about where they followed 0 different couples, there were no linked transmissions to negative partners in those studies, but there were unlinked transmissions, meaning there were HIV transmissions to negative partners from partners that were not in the study. So another thing to keep in mind. So in the end, what this couple chose was Janet chose to take PrEP. Basically, she and James, after long discussions with us, decided that James kind of admitted he felt like there was just so much pressure and scrutiny to be the only person who was really in charge of protecting his whole potential family's risk. And he was really uncomfortable with that. Janet admitted privately to us that even though James was doing really great now in recovery, she was kind of anxious about the possibility of him relapsing and missing doses again as he had in the past. And in the end, it was just decided that they would both feel just so much less anxious and would feel like they had more of a shared responsibility if they were both taking medication, and they could even help remind each other to take medication. And Janet basically said that she felt like she had more control and agency by having the option to take PrEP to protect herself that wasn't reliant on, it was independent of what her partner's actions were. So the main take-home point is that this couple's situation is very different from the one prior, and basically every situation is different, power dynamics are different, and the level of risk aversion is different for each person. And so we meet patients where they're at, and we help them choose the tools that are right for them. And so yeah, and we'll switch gears, and I'll turn over to Guy to talk more about reproductive technologies.
Stay close.
Okay.
Thank you. I brought a little show and tell later. Thank you, and thank you also, Jen. You did a lot of work already, so that makes it easier for us, I think. So we're going to switch gears and talk a little bit about the basics. So the basics about what is conception. So conception is really complicated, and it is really simple also. So let's start with simple. Conception is one egg, one sperm, 2 cells, 1 germ. Embryos are made of this. That is what, you know, if you remember the song Dean Martin sings, memories are made of this. It's that idea, but this is the modern version. That was 1 boy, 1 girl. We don't do that anymore. So, but that's the simple way, right? So an egg cell and a sperm cell meet, and then you have conception. You have takeoff, but takeoff doesn't guarantee landing anywhere on that journey there from the fertilized egg to birth. We can have Houston. There is a problem because, you know, it has to be implanted. There has to be full gestation. And so that's where things can get complicated. And then, as we heard from Dennis so clearly, there is all these other factors of like access to medical care, the legal things that can happen. So there are many complications. But we're here to tell you that HIV is really not one of the big complications. It's pretty minimal, and it gets more and more minimal as time progresses. but the word about that needs to get out. So why do I say that? I say that, I'll illustrate it. So in this whole thing, when you think about conception and gestation, where could HIV be present? So we look at the two places. One, where does the semen, where is the sperm cell? What is its house or its vehicle? It's in the semen. And where is the egg cell? Its house is in the reproductive tract, right? So this is what's present in semen. And these are percentages, you know, but you'll see seminal fluid, other fluids like prostate fluid. There is not usually blood present in semen, but it could be. And then the sperm cell itself. And on the other side, there is vaginal fluids, urine secretions, possibly blood, and then there is the ovum itself. So it's a trick question, and the answer is E. Basically, HIV could be present. It's not necessarily present, but could be present anywhere along those places, except for in the sperm cell itself. It's not in the sperm cell, it's not in the DNA, and it's not in the egg cell. That's where it's not present. So that is why, one of the reasons why, if you think back to when we asked, you know, what percentage of babies will be born with HIV if you do nothing, it isn't 100%. It's between 15 and 45%, and that is, and as we discussed in vertical transmission, that is depends on, you know, is there a lot of blood present during birth? You know, is there breastfeeding after birth? So this also reinforces again what happens when you do take treatment as prevention, or you take PrEP. You basically eliminate the HIV from all of those places where it could be present, right? Now, so that's relatively simple. I think we've established that, you know, with PrEP and TasP, things are pretty much simple. Where things get more complicated, and what Shannon and I see in our reproductive health clinic, is people who have trouble with conception. You know, not because of HIV, but because of other reasons. Could be many. So one of the things that people who desire pregnancy can do is timed intercourse, to have intercourse when it's most likely that they will be able to conceive. Now this, of course, has been known for a long time, and it has nothing to do again with HIV, but there are all kinds of things that people can do, you know, to monitor their own cycle. And there nowadays, well, for a long time there have been, but there are kits around where you can get help with that, and they're available over the counter. So when do we say, is there a problem? The technical definition of infertility is trying for 1 year to conceive without result. And that is true for people under age 35, 6 months of trying if over age 35. So after trying and not succeeding, then it becomes beneficial to consult people who specialize in fertility, which, by the way, is not Shannon and myself. We talk to people about some of the things they can do easily, but when it gets really technical, then that's when we ask help from specialists. Other things to do in preparing for conception. So for people, I split it up here in women and men. I apologize. For people who have ovaries and a uterus, it's useful to test hormone levels in the 3rd day of the cycle. That tells us a lot. And then there's imaging that can be done, radiographic imaging in which a fluid is injected into the reproductive tract to make sure that the ovaries are patent, that there's no blockage anywhere along the line. And for men, for people who produce sperm cells, it's good to get a semen analysis. So let's talk a little bit about what we can do to assist in the process, and what different routes are open to people, and then we'll get to a case. So for people who produce egg cells, you can actually stimulate that process with a relatively inexpensive medication, mostly known as Clomid. And so that's one thing that can be done, so just stimulating that process. Then there is traditional surrogacy, and it was a beautiful handout and slide about that explains it much better than I can, what types of surrogacy there are. But traditional surrogacy is usually referred to as when the person who has the fallopian tubes and the uterus is also the person who carries the egg and the baby. So there's no medical assistance needed there usually. And then there is vaginal insemination. And I'll talk a little bit in the case that we're going to see about when that is helpful. So what are the success rates of these methods? So Clomid is very effective in helping the process of ovulation. It's 85%, so that's pretty decent result. And 43% of people using it will conceive in 3 cycles. But if it doesn't happen in 3 cycles, there's a pretty dramatic drop-off. So again, at that point, so these are low-tech measures, and I love low-tech, because low-tech, don't tell the university, because then, we'd be out of business. But I love low-tech because it puts the power in the consumer's hands, and that's where it belongs. And there is less, medical interference. So we start with low-tech, preferably. If it doesn't work after 3 cycles, it might be useful to consult a fertility specialist. In traditional surrogacy, it's the same as with intercourse. That makes sense, right? And so the same is with vaginal insemination. It's also the same as with intercourse. So we're going to talk about a low-tech case as an example. I met this couple when I was working in Africa. I spent a lot of years going back and forth working in Africa through PEPFAR to build capacity in countries that were now getting access to antiretroviral therapy. And I can tell you that what we now talk about as TasP and PrEP actually existed way before we called it PrEP or TasP. And my people, nurses, were very instrumental in figuring that out. So a lot of the nurses I worked with in South Africa, Tanzania, and other places knew that their partner may have HIV, and they knew that they didn't because they were getting tested regularly. And so they would take antiretroviral medication just as a preventative measure. Same with TasP if they knew that they were HIV positive. This couple were colleagues, and they have been trying to conceive for about 3 years without result. So Miriam is on ART. She has an undetectable viral load. They tried herbal medication, which is the go-to way of doing things, and it didn't help. They also tried Clomid. That didn't result. So we then looked at what could be going on maybe with Rashid, and so I did the best I could. We had access to very little technology, but we did have a high-power microscope, a relatively high-power microscope. So we did a semen analysis. I'd never done one before, but we looked, And what do you look at when you do a semen analysis? You look at three things. You look at the count. Are there sperm cells present? And if so, how many? I failed ridiculously at that because that was very difficult. There's also no standard way of doing it that way, but they were present. And the second thing you look at is, do they look like normal sperm cells? And that's actually not that difficult to see, because abnormal sperm cells, they stand out. And then the third thing is movement, motility. Do they swim? And so any of those three things are important. And I couldn't quite tell whether the count was all right. I could see that there were sperm cells present. I didn't know if it was sufficient. I saw that they looked normal, and I saw that they moved, but I don't know what is normal. Again, right? I never done this before. So after considering many other options, we asked what they wanted to do. Now it turned out that Rashid had a twin brother that he is very close to. And his twin brother, Musa, was also beloved by Miriam. And we thought, well, maybe if the other options haven't worked, maybe that is something we can talk about. It's a form of surrogacy that they were agreeable to. So we talked about the different options, and we discussed the option of Miriam actually having intercourse with Musa, but that was a bridge too far. They love each other all, but that was a no-go for all involved. So we then asked Musa to donate semen, and he did. And I'm going to simulate that here. So he donated semen, and so did Rashid. Think about this. Okay. And then and then we added a little. This is not necessary, but it makes sometimes things easier. We added a little normal saline that was body temperature. I've been carrying this in my pocket for a while now. And this is not sperm washing. This is not sperm washing. But what it is it makes things a little easier. And then, I love showing up.
I know.
My favorite things to do. Then we didn't get a turkey baster. We did not. So, I mean, this often is referred to as the turkey baster method, but a turkey baster is really not the most efficient tool. What you use is this. And then you can, this is also optional, you can use an extension. So first you create a sterile field, right? No, you don't. There's very little sterile in this process, and sterility is not what we're aiming for here. But you do want to wash your hands, you want to keep things clean, I'm sorry. And so then what we did was we used a mixture of Musa and Rashid's semen, and we brought it into Miriam's vagina, and did that. We demonstrated that, and our motto in working in Africa always was capacity building. So our motto was see one, do one, teach one. And so after this, they felt comfortable doing it themselves, and they did so. And the next time I came back, which was 4 months later, they had conceived. And so why did we use some of both? Well, because we'll never know, Musa and Rashid being identical twins, we'll never know who the father is, and that's the way they liked it. So, and by the way, the more twins there are up there in your family tree, the more likely that your branch also will have twins, right? So Miriam gave birth to twins, and they're doing very well, I'm pleased to announce. So these are not them. I just want to make that clear. This is not them. But I'm putting that picture up because they're also twins, and this is a picture of a couple in Botswana, also in the PEPFAR program, where early infant testing was used to determine that the twins were HIV negative. So very happy family there. So higher tech, let's move to higher tech. Sperm washing, we said, that used to be sort of the go-to thing, and it used to be very expensive. It's not the go-to thing anymore in the era of PrEP and TasP, but it's still available. And when you store semen, it is routinely done with everybody, whether positive or negative. They still have separate freezing tanks for people who are living with HIV and people who are not. But that is maybe also ending. And then there is intrauterine insemination, where the sperm isn't just brought in to the vagina before the cervix, but it's actually brought all the way into the uterus, and that takes more technology. You can't do that at home. So donor sperm, I refer to from a sperm bank. Donor egg, frozen. There's still a lot of social justice issues surrounding that, because currently under California law, there needs to be custodians of the genetic material, and in many places they need to be of opposite sex. So we have a lot of fights on our hands still. And then, of course, there's in vitro fertilization. So let's look at the cost. So sperm washing has become cheaper, and there are different techniques. There's centrifuging, and there's the swim up technique, and we can talk about that, but basically that's what sperm washing is. There is intrauterine insemination, which is more expensive, but not unaffordable. And then donor sperm, these are rates that I found repeatedly at different websites, so that's why I'm quoting them here. I asked for confirmation. I called one of the fertility clinics that we work with, and wasn't able to hear back from them in time for this presentation, but these are the rates that are quoted in the resources that you can find. So the donor egg, generally an average fee for that is $7,000 for the donor. That is the personal fee that a donor of an egg usually receives. And then there's in vitro fertilization, which is much more expensive. Egg freezing and storage is also expensive. So between $12,500 and $20,000. So in vitro fertilization, it has also a cost range, but generally is between $15,000 and $20,000 per cycle. And that again, it varies from area to area, from state to state. But it's expensive. It's not the kind of money that our clients usually have. Success rate is about 40% on average. So this is basically all I'm going to say about high tech, except to illustrate it with a case. So Shannon and I saw a couple, and are still seeing a couple in our clinic, who are, by the way, from East Africa originally, and they desiring pregnancy. Both are living with HIV. Both are on ART, highly effective, have had undetectable viral loads forever. And the problem here is that Zula is over 42 years old, and we cannot refer her to our clinic, our reproductive clinic at General Hospital, because there's a cutoff at a certain age. But we called around and found a local fertility clinic that was willing to work with them. And we made an agreement. So we, at General, were going to do all of the lab work that was needed. And there's a lot of lab work needed. And then we would send that to the fertility clinic. they were willing to do the consultations for free, which is huge. So they also were willing to give a couple of break on the IVF. And they have a community of their compatriots here in the Bay Area that really supports them and did collections for them to help pay for it. So it's a beautiful, beautiful story. They're currently traveling, but when they come back, we expect that they will start their first cycle. So here are some of the resources. At general, we have the REI. Here are the referral criteria. I'm not going to go into depth about that. And then I researched what is available in the Bay Area outside of public health, outside of general. And these are the clinics that have and a good reputation and accept people living with HIV or partnered with somebody with HIV and offer the full range of services. There are many more agencies that claim to be fertility clinics that either are not or that don't accept people with an HIV positive status. So these, it's a partial list, there are more, but these are the ones that, that consistently come through as reliable and have a volume of clients that supports their thing. So very important to note that the services offered and the costs differ from clinic to clinic. So this is worth researching. Bonus case. So this is a story about my own life. This is me and my partner, Steve, who I've been fortunate to be married to for 27 years this year. We met in 1992, and shortly after we met, people thought we were nice enough that they thought maybe they could be donors. Separately, we got asked by separate individuals. It caused us to discuss, what we thought about family. We had never thought about this, and we thought it's not that important for us personally to leave our DNA in this world. Neither one of us had strong feelings about this, but we did like the idea of being parents. So we instead thought, well, there are a lot of kids there that need parents. Why don't we consider adoption? Then shortly after, we went through a rough patch in our relationship, and we stopped that discussion. We actually lived separately for a little while. And then we got back together, and the discussion came back up, and we actually took the next steps. We did an orientation, adoption classes, we got our house inspected, very important step. Is it child safe? Does the child have a room of their own? All that kind of thing. And we became classified as foster parents, which is the first step. Pluses for us were that we're an interracial couple, we're open to adopting special needs kids, and we had healthcare and foster care experience in the past. Not a factor at all, and remember, this was 1998, not a factor at all was HIV status, even back then. But this is here in San Francisco. Had we been in another state, the story might have sounded quite different. So I want to make a major plug for some people who are here today. They're over there, who work with adoption, and they have fantastic brochures, and they're really able to talk you through the process of the steps it takes. All right, we didn't end up adopting. We ended up working in Africa half the year, and so it became impractical, but we are very happy as uncles. All of this to say, there are many different possibilities, there are many different ways, and HIV is not a factor in how you get to that first mountaintop. It can be a rough road, it can be a relatively easier path. Most paths are actually not that easy. Whether it's, regular conception in what we call the old-fashioned way, or surrogacy, or IVF, there are always barriers, and HIV should not be one of them. It should not. We feel strongly that everybody has the right to parenthood. Nobody should be denied parenthood. Nobody should be forced onto parenthood. And everybody deserves to plan their parenthood, to have a planned parenthood. Planned Parenthood, I just made a plug for you. So, thank you.